My name is David Chong. I'm on faculty at the University of Oklahoma. I've been there about 10 years. I've been in the IPSG group for a few years now, and I've somehow become in charge of overseeing all the MRIs. So I've personally been able to parse through hundreds of these, which you learn a lot from if you see enough of these. So I'm just going to kind of tell you guys about some of the research we've done in this and some of the publications we have, and just tell you about why are we getting MRIs. So why an MRI? So if you get an X-ray, they tend to have a time lag, and so often you will get an X-ray that looks totally normal, and the kid has Perthes, and everyone misses it. The ER misses it, your doctor misses it, because there's a time lag. The bone is still intact and hasn't died yet, or hasn't just fragmented yet. And so you won't see obvious changes on the X-ray sometimes. And so the MRI gives you real-time severity of the disease. It also gives you the ability to measure it three-dimensionally as well, and not just see in one plane. So on this X-ray here, you can see this one's pretty obvious. This kid has Perthes here involving the whole head. The second one is not so obvious, but in fact, if you get the MRI of this hip, and I'll show you later, that's just as involved with the head there. That's just earlier in the time. So why a perfusion MRI? So non-contrast MRIs might still look normal, and so they can deceive us and make us think there's more perfusion in there than there is. The contrast goes in living tissue, not in the dead tissue, so it shows up black. But if the tissue still has some fat in it, sometimes it doesn't look that bad yet, especially without contrast. And then if we subtract the non-contrast images from our contrast images, we'll actually notice that it reduces the background noise and gives us a much better picture. So as you can see in these panels here. So I'll just show you, for example, this is that kid from earlier. This is a 7-year-old female in my practice who has left hip pain, and she had some minor findings on X-ray. You can see here, if you compare it to the other side, there's definitely a slight difference in that head. It's just a slightly less round there, but it's not very obvious. Now, if you get an MRI without contrast, this is what it looks like. And you'll see just a faint blackness on the top of that head and just some mild flattening, suspicious of Perthes, but it seems that's pretty mild. And so one might say, well, it's not that bad. It's not involving a lot of the head. Maybe we don't have to be so aggressive about treatment. You get the MRI with contrast, and you start to notice some more changes here. You can see compared to the other head, this one's a bit darker now. Still doesn't look like it may not be that bad, but we're a little bit more suspicious. You get the subtraction, and now you can confirm here that this entire head is nearly involved. There is almost no blood flow to this head at all. And so that is what's been driving a lot of our what we've been doing recently is trying to figure out how do we treat Perthes. But now that we have a better way to see how bad your Perthes really is, better than X-rays, now we can probably have a better sense of where they're going. So recently, from a publication standpoint, a couple of years ago, we published this paper in the journal Pediatric Orthopedics, basically looking at how well can we calculate how bad Perthes is based off these MRIs. And so we actually took 14 of our surgeons in IPSG, and we looked through 122 MRIs, and every person measured the dead spots on Perthes using their eyeballs, and number two, with computer software. And this computer software is called HipVasc, and it's a software we use it to analyze each image one by one. It's been shown to be accurate in some other studies we've done, about 90%. It takes about 5 to 10 minutes per study to analyze, so it's not an easy task necessarily when you're faced with a lot of these to do. But what it does is it gives you a heat map of the scans on the MRI, so you can get a sense of how bad the hyperperfusion is, and you can actually have the computer calculate the dead spots, so you know what percent of the head has actually died. Here's another example of MRI versus HipVasc with the same images, and you can kind of see the extent of the hypoperfusion throughout the head. But it's nice because it'll kind of make it a little clear as to which parts of the head are actually dead and which ones are not. So in our study, we found a really good correlation between visual estimate and computer measurements. They weren't perfect, but they were really close. And we did find that people tend to overestimate in general. People would tend to think that the hypoperfusion was more than it really was based on the computers. And that's probably because we're looking at three-dimensional objects with 2D cuts. We also found that the measurements between raters was also very consistent. So basically, people in general are good for measuring, and we don't necessarily have to use computers. And so your doctor in the office doesn't have to use a computer to measure how hypovascular it is. So we found good correlation between those two. We found that it's consistent and accurate. And so at the end of the day, yes, we can just use our visual estimation. We can use our eyeballs just to measure how bad the femoral head is. And this is in terms of using your MRIs. So new research that's going on right now, we're currently looking at how safe these MRIs are, as well as how easy is it to use. So from a safety standpoint, we've had a 493 perfusion MRIs so far over these past several years. We've only had 3 complications reported to date. One was a minor allergic reaction to contrast, and 2 were nausea and vomiting, likely induced from sedation. To verify that there weren't other complications out there, we sent out a poll to all the IPSG centers, and so far, 29 to 45 have reported back, of which they've not seen any major complications. So overall, we feel like perfusion MRI is still a very safe thing to do. So the bigger question is, how do we get a good quality perfusion MRI? Because children move, and you get this motion artifact during the scan, which causes blurring. That makes it hard to measure, if not impossible. I mean, you can still get a general sense of things, but it's really hard to look at. So this is an example of a patient moving during an MRI. And so these scans can actually last about 45 minutes when you do it with contrast. And then patients will move in between the scans. And if you get that, then when you try to do subtraction, you end up with this thing called ghosting, where you end up not being able to make your measurements because the subtraction images don't look good. You can still use the contrast films and make some judgments, but it's not as good as subtraction. And so we really want to know is, what factors can we change to get better MRIs? Could it be the anesthesia we use? If we sedate them, can we use video goggles? Could we shorten the exam? Does the MRI strength matter? Does the age of the patient matter? Does the kid have ADHD matter? And so our study so far has shown we've had about 493 MRIs we've looked at. Average kids are just a little bit over 8 years old, and they range from about 3 to 16 years old. 25 of these MRIs were no good because of technical issues, which were not patient faults, which left about 468 MRIs to look at. So of these MRIs, 79% were good quality, meaning pretty much 4 out of 5 MRIs we do fine. We find that a lot of the motion artifact comes about, and that was 20%. And so we looked at the ones that had sedation versus not, and you can see here that light sedation didn't really change our numbers very much, just a slight improvement. But hey, hi, can you go over there, Sam? Hey. So what we noticed is that with general anesthesia, it actually improved our numbers by almost 10%. And so certainly, general anesthesia might always be better from our standpoint to get a better MRI, but that is certainly a risk to the child. And so really we want to know, at what age is general anesthesia worth doing? We also found that poor quality MRIs took about 20% longer to take. So we knew that study duration, or basically the longer they spend in the scanner, the more motion they're going to have, which makes sense. We also found that we were probably more successful to get MRIs in kids with general anesthesia at under 8.5 years of age. So that's a little bit of a cutoff maybe where you might want to consider doing the MRI if it's under that age, or sorry, anesthesia under that age. We also found that the 3T versus a 1.5T magnet didn't make a difference. So you'll have a lot of people touting the big, strong 3 Tesla magnets. They do give higher resolution. We really didn't find that it made a big difference in having a good MRI. The 1.5 is really just good enough to see it. So I don't think you have to worry about that so much. If we divide into age groups, you can see here that in the younger kids, we had a much higher success rate with general anesthesia. In the 6 to 8 group, we found pretty much a little bit better, and then over 8 really didn't find much difference between the groups. So again, suggesting that younger kids, but again, these under 6 age group doesn't necessarily need an MRI. So these are kids that, for whatever reason did get an MRI with sedation, but a lot of these kids don't necessarily need an MRI because they do well. So it kind of just depends. So how do we get a good MRI? I would suggest you find someone who's been doing this protocol to do it, make sure it's done right. We can certainly be in contact with any doctor if you need to get a protocol, but there's specific protocols and ways to scan and then ways to process the images that can be pretty technically difficult. And so every hospital should have the tools to do it, but it's just a matter of getting it, make sure it's done right. So everyone in the IPSG has sent and submitted MRIs to us, and we basically screen them and make sure they're doing it right and correct them to make sure that it's done correctly. So bottom line is, we've done the screening for you. So if you find an IPSG surgeon, they should be able to do it for you. Okay. We know that faster scans are better, so we want to avoid doing extra studies, which sometimes happen. We didn't find light sedation or video goggles did change very much. General anesthesia generally was about 10% more successful. And so I would say over 8.5 years, you probably don't need anesthesia. But again, every kid's different. If your kid is wild and crazy and will not sit still, you might need to do something if you really want to get a good scan. And then under 6 years, obviously we had better results with anesthesia, but a lot of these kids may not necessarily need an MRI. So that's it from my standpoint.